So this is the only slide I have. This is the title slide and the summary. That's it. Endo rules. So I apologize. I'm trying to make a poor joke, but I love my surgeons, the ones that I work with. I love you, Steve. So we're talking obviously about this clinical trial. Kudos to the people who did this trial. My God, when I was reading about it, I mean, it's I think 5 or 6 countries, 150 sites. Predominantly vascular surgeons, I think about 75%, and then 70%, and then 15% IC, 15% IR. So a lot of different sites, a lot of different skill sets, a lot of different personalities. But when we look at this trial, right, what is this trial? So when you try to evaluate a clinical trial, it wants to answer a question. So the question is, what's better, a vein graft for a bypass or endovascular therapy? So you have to design your clinical trial to answer this question as best as you can, correct? So one of the things that I noticed right off the bat was it was a composite endpoint. They looked at major adverse limb events, which is above the ankle amputations, death from any causes. And then one other thing I saw was that only about 85% of the endovascular therapies were even successful, whereas there was about a 99% success rate with surgery. So 99% of bypasses went off great. 85% of the endovascular therapies were successful, and we'll look at that too. How was that assessed? So 15% of the time, it was deemed a failure. So those two things kind of made me think, really? Let's look at the data even more. All right, so the second thing that you say when you're designing a clinical trial is you want a result and you want some sort of generalizability to the population, to the PAD or the CLTI population. So you want to say, well, my results are applicable to everybody. Well, let's take a look at this. So this is the demographics of the patients. No octogenarians. I bet anybody that does more than 300 CLI interventions a year like I do, you definitely see octogenarians. Heck, you see nonagenarians too, right? Definitely do. So octogenarians were out, number one. Only 28.5% of these patients were women. We know women with CLTI do worse than men, right? So definitely underrepresented. So predominantly Caucasian patients, minorities, not very well represented. We know they lose their limbs 3 to 5 times higher at a higher rate. Right? So there's issues with how the patient population was selected. I don't know about you guys, but I practice in North Carolina. I'll be happy to see a BMI of 28. These are not my patients. Nobody has a BMI of 28 with CLTI in North Carolina, at least in my practice. One other thing is, I always go back to David Armstrong's paper about the renal foot. So he published a really important, very insightful paper on how kidney disease affects the arteries. And patients with kidney disease are often the ones that don't have limbs, right? The worse the kidney disease, the more likely that you're going to lose your leg. So patients with kidney disease, I don't know how well they were represented. So let's take a look at what I think they could have done better or they didn't do very well. They selected healthy patients. Patients who could get either a bypass or endovascular therapy. That is not the CLTI patient that walks into your office all the time. So they excluded a whole bunch of patients, and like I said, there was some selection issues with the type of patients. And patient enrollment into the arm, whether they got surgery or endovascular therapy, relied only on the judgment of the physician at that site. And we know that can be variable, right? So not everybody can get this. A lot of the patients in the trial got this, a fem-tib bypass surgery, right? These are more like my patients. An 82-year-old with a bad wound, with low EF, congestive heart failure from a bad aortic valve. Vascular surgeon said, I can't bypass this patient. The cardiac surgeon said, there's an open wound. I can't do a TAVR on this patient. So this patient kind of kept going in circles, somehow found me. We did this with lidocaine, with her sitting up because she was still orthopnic, but 82-year-old still lived by herself, very independent. So these are the typical sort of CLI patients that we get to see, right? So did her entire revasc only from the foot. And then she healed up her wound, got her TAVR, very, very grateful. Comes back to see me every 6 months, right? So the other thing, that was a good segue, I think, into operator skill and experience. So there was no objective way by which they realized how good the operators were when it comes to endovascular therapy, especially if you're saying 15% of those were failures, right? How many procedures did they do? I mean, just this morning, somebody was talking about how higher volumes lead to better outcomes, right? It's like anything else. You do more cases, you tend to be better. So there was very little, publication about how many procedures they were doing, what percentage of their patients were CLI. So, for instance, in my practice, about 7% of the patients I put on the table are claudicants. 93 are Rutherford 4 or 5. 93%. So the definition of treatment success was also left to the individual operators. There was no core lab adjudication when I looked at the paper. So whether the procedure, the endovascular therapy failed or succeeded was just so subjective, right? And this trial was done over a long period of time, during which there was the whole paclitaxel controversy. So you can say that patients were probably not treated adequately well during that time with the drug-eluting therapy. Patients were followed for a long time, during which, in August 2014, the pinnacle of endovascular therapy was like a jet stream or a hawk, right? Since then, we've had a ton of other things come in. So you can always say that they probably didn't get treated adequately based on the technology that was available at that time. So one other thing that bothered me was, again, during the PTAB dinner yesterday, one of our vascular surgery friends said, well, we're not in the process of making them live longer. We want to give them a quality of life. I mean, jokes aside, I think that's a valid point. Vascular surgeons can't take care of everything, the whole patient as a whole. So I think it's important that we focus on meaningful outcomes also, like pain, limb salvage, mobility, overall quality of life, right? So in addition, there were a lot of patients that crossed over. We'll talk about that. So to try to sum it up and keep me within time, this was the single most important reason why I don't use the results to generalize care for my patients. So you cannot have a 15.3% failure rate. When they published PROMISE-2 in 2023 in NEJM, there was a 99% success rate. So you can do a DVA 99% of the time, but you can't do endovascular treatment 99% of the time. That, to me, kind of made me think twice. And then using a composite endpoint and not using other patient-centered outcomes kind of makes you think again, did we answer a lot of questions? Also, the objective competency requirements for endovascular operators, that was never talked about. We talked about this, did they get all these therapies or not? Also, the skill set was not talked about. Did they use alternative access? When did they declare failure? A bunch of other things like this, right? So when you look at the other numbers, there were quite a few patients, about 363 out of the 1,000 or so patients that withdrew from the clinical trial. The data was missing. This was about 20% of the patients. 20% of the patients. So now you're talking about generalizing therapy when 20% of the patient's data is missing or has faulty information, right? So who is Steve's perfect patient? Has to be cannot be a minority race, has to be less than 8 years of age, definitely not from North Carolina, and has to be healthy with no heart, liver, kidney disease, no superficial venous disease, which we know is 5 times more common than arterial disease. So you got to have a great saphenous vein all the time. These are the patients that have to immaculately follow up with you, give you perfect data, and you have to have an operator that doesn't do many cases. So this is the best CLI patient, in my opinion. So that's why I feel, while the trial provides some great insights onto who would benefit from a bypass, I don't think everybody should get a bypass.